is, I think that we have to, as a nation, worry about our health.
Yeah.
We sit at the computer, we sit at our Blackberries, we play games, and we don't eat food, we don't interact with one another, which is good for our mental health and good for our families and good for who we are. And we don't walk around and get exercise. And if we could encourage everybody to do that, we'd need a lot less health care. As you say, there just is not enough of health care resources to take care of the amazing amount of care that's going to be needed. And so we're going to have to change the way that we do it.
Good thoughts. There's a concept that gets thrown around from a buzzword perspective of cost shifting. We've heard it already here. Those of you who know me know that I'm a very visual person and I like images. The images that we've selected for this section is Robin Hood. So we rob from the rich and give to the poor. And understand, what you need to understand is that the government is the poor and you are the rich. That's the way the Robin Hood deal is going. So let's kick off this section and talk a little bit about the realities of cost shifting in terms of what each of you experience in the cost shifting world. I think we're going to start with either Liz or Tim. Jump in.
Well, cost shifting, I think we talked about it a little bit. You know, you pay one thing for Medicare and another thing if you're primary care. As a large not-for-profit organization, Sutter, we deliver a lot of uncompensated care. And we're trying to, as an organization, figure out ways to do that more cost-effectively. When people don't have insurance or when they're underinsured, they wait till they're really sick to go to the doctor, and that costs a lot more. One of the ways that we're managing trying to deal with this is we're partnering with federally insured, federally qualified clinics that take care of the poor so that we can get that care early on rather than wait till the patients get very, very sick and end up at the hospital. But the bottom line is, you know, a lot of people don't have any health care until they're in dire straits, and then it just costs many times more.
At Packard, being a children's hospital, most children's hospitals do a lot of care for the poor, just by definition, because that's a lot of the kids that get sick or injured and whatnot, or born with various congenital heart defects, things like that, have more of a propensity to be born with a lot of issues because of poor prenatal care and all kinds of other reasons. So about 45% of our payer sources out of 100% is coming from the state of California. And so we get paid, on average, about 8 cents. Of every dollar we charge, we get paid about 8 cents. Our costs run right around 30 cents is what it costs us to provide care, all in. So we lose a lot of money, around 150 to 170 million right now a year on taking care of Medicaid patients. So that money we tag on to everybody else's bill, essentially. And it's about a 25 to 30% tax is what it is, right around there. You figure it's just like a tax, we're passing it forward. And that's what, you know, the purest form of cost shifting is. And it's one of the reasons, you know, that a lot of the private healthcare organizations, and it's one thing to I want to pick on Kaiser. I think Kaiser does a wonderful job of a lot of things. Yeah, Ernie will hit him. but
I'm ready.
Yeah, Kaiser doesn't do a ton of Medicaid work or whatnot. A lot of the private hospitals do, and so it's one of the things. Say, wow, you're really expensive, and it's like, well, if you could knock that quarter off the top, now that's how expensive I am. If you're looking commercial to commercial, toe for toe. Yes, we're expensive because of some of the things we do, especially at Packard. We have the highest case mix index in the United States right now as far as children's hospitals. It's over 2, which is a measure of acuity of how ill people are. And it's us and Atlanta Children's go back and forth pretty much every month with who's got the highest.